Thank you, David. Thank you, Heidi, for the invitation. It's a real honor to be here. It's the first time I attend Coeliac UK. And I'm impressed by the quality of what's being presented and the discussion. So I'm going to tell you about therapeutic advances. What's the state of the art in drug development in celiac disease? First, I need to tell you my disclosures. I've been working in celiac for a long time, so I have a lot of disclosures to make. I am the co-founder, chief scientific officer of a company called Provention Bio. It's a public company, and we have a vaccine in development against the enteroviruses which have been associated with celiac disease. So we hope that that vaccine could reduce the prevalence of celiac disease. We also have anti-interleukin-15, which is a monoclonal antibody for the treatment of celiac. I'll tell you about it. It's in phase 2B. Prior to that, I was with Cellimmune. Prior to that, with Alba Therapeutics, all drug development companies in celiac. I am also a partner of Biomedal, and the CEO is right here, Angel Cebolla. This is the company in Spain which developed the tests to detect gluten consumption. I need to say, if you can avoid gluten, you don't need a drug. So we're developing drugs for people who can't avoid gluten despite using these tests. And we took those tests over the counter for patients to do them at home, and that's glutenostics. So the first question is, do patients really want or need medications? A few years ago, I used to go to conferences like this, and patients would stand up and say, we don't need you, greedy pharmaceutical company, go back where you came from. I'm serious. I got these comments. So then I was very relieved to see actual work published when patients were asked, do they want a medication? And it was very interesting. Patients said they are not interested in going back to eating gluten. Patients realize gluten is like poison. They don't want poison and an antidote. What they want is something that helps them achieve a normal life on a gluten-free diet. If you go through the burden of the diet, you want the diet to work. The diet is extremely burdensome. As we all know, celiac is the second most burdensome disease after end-stage renal disease, according to research published by Harvard. So only people on dialysis feel that their lifestyle is impacted more than celiac patients. Patients want something to protect them from cross-contamination as an adjunct to the gluten-free diet. The problem is it takes so much work and so many failures to develop a single medicine. We don't have not even one medicine for celiac. We don't even have a phase 3 drug. You know that it takes 10 to 15 years to develop a medicine. You need to screen thousands of compounds over many years in animals, preclinical studies. Eventually you get into phase 1, safety and tolerability in healthy volunteers. Then phase 2, you prove the drug works in patients. And then finally phase 3, you confirm that the drug works and is safe in thousands of patients. At the end of this process, only 1 out of 1,000 drugs will survive, eventually will be approved. So it takes a lot of time and money. It takes on average $1 billion to develop a medicine, but that is not because it costs $1 billion to do this, it's because 90% fail. So that figure has taken into account the failures as well. The phase 3 program costs about $100 million in itself. So we need multiple shots on goal because we know most are going to fail. This is the cartoon that you've probably seen before, the pathophysiology of celiac. Gluten peptides cross the epithelial layer of the gut. They get deamidated by transglutaminase. They get presented by the antigen-presenting cells to the T cells. The T cells will activate the B cells. The B cells will produce antibodies against gliadins and against transglutaminase. That's when the autoimmune process starts. This is the so-called adaptive response against gluten. And then there's an innate response, which is very early in the process. Gluten directly stimulates the production of interleukin-15, which activates these cells called the IELs, intraepithelial lymphocytes, which are in between the inner layer of the gut. And these cells destroy the gut wall. They are responsible for the damage of the gut wall. So just in 2010, we had 4 approaches. There was a company called Alvine with glutenases trying to digest gluten. They made it through phase 2B, and then the drug didn't work in phase 2B. I was working at Alba. We had a drug to reduce intestinal permeability. We also made it through phase 2B. The effect was not very prominent, and we actually sold this drug to another company which is going to do a phase 3. It's called Innovate. There was a trial to block these T cells, chemocentric. This trial failed as well. The drug was not safe. And then Immuson T is the company developing the vaccine. I'm sure most of you have heard about this. This is a secondary prevention vaccine. It's for people who already have celiac disease. It's to desensitize patients, such as in allergy. You get shots to desensitize yourself. That's the vaccine. They are now entering phase 2. And then in Australia, they were infecting people with worms because that deviates the immune system towards the worms and away from the gluten. It does work, but most people don't want to have worm infection. So it hasn't progressed beyond phase 2 so far, but it does reduce symptoms. It does not help with the gut inflammation. So what has really changed, and it's in great measure thanks to patient advocacy groups like Celiac UK and other groups in other countries. There has been lobbying, there has been advocacy, and a lot of people have entered into celiac disease. They know celiac is a very prevalent disease, the most chronic gastrointestinal autoimmune disorder, and patients need help. So there has been a big explosion of companies now. We have more than 20 approaches in celiac. And this is the current state of the art. And all of these slides are available to you, so no need to take notes. So the glutenases are growing. You have now Immunogen X. In phase 2, they took the Alvine glutenase, and they're trying to do it in a better way to get past phase 2. But new companies, PVP Biologics, and here it's interesting that now Big Pharma is finally taking notice. So companies like Takeda, one of the largest companies in the world, is sponsoring PVP Biologics. In addition to blocking gluten or digesting gluten in the lumen, there are attempts to modify how gluten gets processed by the microbiome and the use of probiotics. There's the attempt to prevent gluten from getting through the gut. I mentioned to you, Innovate is developing larasotide to reduce intestinal permeability, the so-called leaky gut. There are many companies now working on interleukin-15, and my company is one of them, Provention Bio, with an interleukin-15 antibody, trying to block IL-15, and I will show you that we have achieved proof of concept, and this is very novel. There's a transglutaminase inhibitor. Sedira and Dr. Falk are blocking transglutaminase, preventing that deamidation of gluten. They're in phase 2. Everything here in green is in clinical trials, and everything in blue is in animal studies. Takeda has a very nice molecule, vedolizumab, which is now approved, and it prevents the migration of activated lymphocytes or immune cells to the gut. And they are now starting some celiac trials. And finally, the NextVax vaccine is getting into phase 2A, and some other tolerance-inducing agents are being developed as well to try to prevent that tolerance break down against gluten and restore immune tolerance. So this is very promising. If you remember the previous slide, 9 out of 10 drugs fail, so you need 10 shots on goal to get one drug approved. We have reached that critical mass, so we feel there will be a drug approved for celiac in the next 5 years, probably. Now I'm going to tell you a little bit about interleukin-15. This is a key molecule which stimulates these cells, the intraepithelial lymphocytes. They are the cells that destroy the epithelium of the gut. They cause epithelial damage. And also they are the cells which at some point grow without control and cause refractory celiac disease. Refractory celiac is a lymphoma. It's a cancer of your gut lymphocytes. And it's due to the exposure to gluten over many, many years. That's why it's so important for celiac patients to completely avoid gluten, because otherwise you can develop a lymphoma which affects 1 in 200 celiac patients. It's relatively common, fortunately not very common, but 1 in 200 celiac patients will have a lymphoma, and that's not good. So we first tested interleukin-15 antibody AMG 714 in partnership with Amgen. We tested it in Finland, Professor Markku Mäki and his team, and we did a gluten challenge study. And this was really interesting. We enrolled 63 patients. And of those 63 patients, we had asked them to be completely gluten-free for a year. They had no symptoms. And we measured their gluten in stool and in urine with the biometal test, the glutenostics and biometal test. And what we found is that in the first 2 weeks of the study, there were patients eating gluten despite telling us they were not eating gluten. This is contamination. And for those patients who were eating substantial amounts of gluten, we checked their guts, and the guts were atrophic. They had mucosal damage. For patients who didn't have a lot of gluten, in blue, the guts were in better shape. So then we subjected those patients to a gluten challenge. We gave them 2.5 grams of gluten per day for 10 weeks. So this is a very substantial gluten challenge. These patients are real heroes. They are willing to take gluten in order to test the drug, but there's no other way. You cannot test the drug for celiac if you don't do a gluten challenge. Towards the end of the study, we noticed the patients stopped taking the gluten. They said it's enough. They didn't want to take it any longer. But what's also very interesting is those patients who at the beginning of the trial were getting contamination for a while, without the challenge, they were able to go back to 0, no gluten, but it didn't last long. After a few weeks, the contamination came back. This is the real problem of celiac disease and the gluten-free diet. It's so difficult to maintain a 100% strict gluten-free diet. Gluten keeps popping up in your diet, and this causes the mucosal damage. So I'm going to show you results for our drug in these 2 groups of patients. On the left, I'll show you the gluten challenge, and on the right, I'll show you the patients who have contamination, but no challenge. The first thing we check is the gut histology. The VHCD is just a measure of how well the gut is doing. And here we have good news and bad news. The bad news first is in the patients eating high-dose gluten challenge, the drug did not work. So this drug does not allow normal consumption of gluten. All patients got sick. But in the patients exposed to low gluten exposure through contamination, increasing the dose of drug was able to almost completely prevent any further damage to the gut. That was encouraging. We then looked at the intraepithelial lymphocytes, and we found a significant reduction in the patients eating the gluten challenge. There was a reduction in inflammation. There was actually an increase in weight, which was very interesting. Placebo patients, when exposed to gluten challenge, lost weight, but on drug they gained a little bit of weight. It's a good sign for better absorption. And I'm sorry, these slides are very science-oriented, but this is very important. The celiac disease PRO, this is the patient-reported outcome. This is the test that is necessary to get the drug approved by regulators. This is it. This is the only test regulators accept for approval. And you need to have a statistically significant results, meaning a p-value of less than 0.05. So we were very happy that you can see this is an increase in symptoms. It measures celiac symptoms. With the gluten challenge, the symptoms went up a lot until the point when patients threw out the gluten. On drug, there was less symptoms and it was significant. We used other measures of celiac symptoms like the GSRS and we got similarly good results. We also asked the patients to rank their stool consistency. This is the Bristol stool form scale. On placebo, in the placebo group, patients had increased diarrhea, indicated by the elevation here, but on drug they had decreased diarrhea. It was very significant. At the end of the study, patients in the high-dose AMG 714, they all appeared to have no disease activity according to the physician global assessment. So clearly, this drug was able to prevent or ameliorate the effects of gluten in celiac disease. And in terms of safety, there was no serious adverse events, which is very important because we cannot develop drugs that are dangerous in celiac because you have the gluten-free diet. Remember, this is a drug for people who don't manage to conduct a perfect gluten-free diet. So now this drug is going to move forward into phase 2B, and we hope that we can work with Professor Sanders and other British and Irish colleagues to do the phase 2B trial here, among other countries. And now, very rapidly, I'm just going to tell you that this drug also worked in refractory celiac disease. Remember, this is a cancer. This is the T-cell clone that dominates. It's one type of lymphocyte that starts growing without control and ends up killing the patient. 50% mortality at 5 years once these T-cells get disseminated into your body. We did a clinical trial with a high dose of drug, and the first thing we saw is the drug stopped the growth of these malignant cells. On placebo, they kept growing. On drug, they didn't grow. We look at the clonality, which is an indicator of how malignant they are. On placebo, half of the patients had an increase in clonality. On drug, none. And then on drug, patients had improvement in histology and had improvement in symptoms. They go down while on placebo they go up. So very successful results. This work was selected for the presidential plenary session at Digestive Disease Week, which is a big honor. And we did have some safety issues with this molecule because these patients are very sick. These patients who we enrolled in the trial had all undergone bone marrow transplant and chemotherapy for their lymphoma. So then when we gave them on top of that AMG 714, a few patients had infections, a couple patients had infections. However, when you put it in the context of a lymphoma that's going to kill you, the benefit risk appeared acceptable. So now this drug has been made available for free by Amgen to any clinician who wants to treat refractory celiac patients through a compassionate use program. And that's all. I really want to just stress that things are changing in celiac. We need to thank all the patients who have participated in investigational clinical trials, because you are making possible that the next generation of celiac patients will not suffer the consequences of the disease, or maybe we can prevent it altogether. So thank you to all patients who make research possible.